to our next panel, looking at how to take call. I will pass it over to our next pair of committee members, Cassidy and Patrick. Take it away, guys.
All right, thank you. So as he said, my name's Cassidy. I'm a fourth-year student at Texas College of Osteopathic Medicine. And then Patrick is on as well. He's a third-year student at Loyola Chicago Stritch School of Medicine, and we will be moderating this panel on how to take call. So we have a great group of panelists who are excited to share some tips and tricks with you. So like our last panel, we will call on a couple panelists to answer each question. But then, of course, other panelists are welcome to chime in at any time if you have something to add. We may have some extra time at the end, so if you have any burning questions, be sure to put them in the chat. And I'll go ahead and hand it over to Patrick.
Thank you, Cassidy. And again, we're happy that all of you are with us today, and especially thankful for our 5 panelists right now who are about to share all their wisdom and tips and tricks. As far as introductions, first we have Olivia Panchal. She's a fourth-year medical student at University of North Texas College of Osteopathic Medicine, incoming ortho resident at Franciscan Health in Chicago. She's from Oklahoma City and attended USC for college, and she's also actively involved in the American College of Osteopathic Surgeons. We have Dennis Sievers with us, fourth-year medical student, Kaiser Permanente, and he's from Southern California and went to UC Riverside for undergrad. He went through the residency application process in 2024 and completed 4 sub-Is with us. Next, we have Sam Fuller, PGY1 at University of Buffalo. He's from Cleveland, Ohio, and then went to St. Bonaventure University in New York, and he attended George Washington in Washington, D.C. for medical school. We have Andy Harris, PGY4 at Johns Hopkins. He's originally from Boca Raton, Florida, and went to undergrad and medical school at the University of Florida. He's looking to pursue a fellowship in hip and knee replacement. And last but certainly not least, we have Dr. Ward, board-certified pediatric orthopedic surgeon, earned his Doctor of Medicine from the University of Texas Health Houston, and completed his residency there as well. Went on to complete fellowship at Duke and University of North Carolina, and he's been an assistant professor at Texas Tech and serving the El Paso community since 2021. Just wanted to say, we just had a great panel on the soft skills. It seems like that's a high focus as far as your sub-Is. Our next 3 panels will be on call, the OR, and then clinic, and we'd love to see those soft skills advice woven into these questions. However, we're also going to focus on maybe some of the more technical logistical aspects of, for us, how to take a call. And with that, I'll pass it back to Cassidy for our first question.
All right, so we'll start off with just a general introduction to orthopedic call shifts. So I'll direct this first question to Olivia first and then Dennis after. So can you guys just tell us a little bit about what a typical call shift looks like as a fourth-year medical student?
Sure. So I think this depends on the institution. It can vary quite a bit from rotation to rotation. And I also think the expectations of medical students change throughout the year, depending on whether it's early in the year towards like getting closer to interviews and application time. But generally, you're going to be with the resident overnight and you're going to be waiting for consults. So anytime the resident gets a call for a consult, I try to listen, try to get like the EMR number or try to get like basic information about what's going on. If I have EMR access, I'll look up that patient, try to see if there's x-rays available, kind of get an idea of what we're going to expect of this consult. And depending on the institution, they might allow you to go and see the patient first before the resident goes to see them. So you want to ask them relevant questions, do a physical exam. So for example, if they have like a distal radius fracture, you would want to check their neurovascular status. You would want to, if you think they might need surgery, ask them the last time that they ate, their smoking history, things like that. Get a good history and physical for the resident and then report that information to the resident. And then while you're doing that, start thinking about what you might need. So again, if it's a distal radius, if you're going to need a sugar tongue splint, go ahead and get those supplies ready. Depending on, you know, the relationship you have with your resident, you might go ahead and roll that stuff out, or they might want you to wait and kind of see like what you know. So that kind of depends, but always be anticipating about what the resident is going to need. If you need a C-arm, if you need weights to hang the arm, etc. So always be thinking about that. So that's kind of the the basic thing, and you kind of do that with each patient as the night goes on. But always try to anticipate what the resident is going to need, not only because it's helpful, but also it shows that you have an understanding of the patient and the orthopedic situation at hand.
Yeah, I don't really have a ton to add, other than I would say at the places I went to, the way it would work is if you were on call, what you're doing during the day is kind of just going in the OR, doing your normal daily activities. You might not be with the call resident at that time, and then whenever the last case finishes, then you'll go find the call resident and basically do everything that Olivia was talking about.
Yeah, Olivia, that was a really good walkthrough about the variability depending on when you're taking calls with the ortho residents, as well as just being proactive, kind of the walkthrough. So we'll want to delve into that more, but excellent start for us. Next question we have is on preparing for call before you're even on a call shift. And I'll start with Dennis this time, and then we'll get Sam's thoughts afterwards. So what are some of the ways students can prepare to take call? And what skills and practices should students be familiar with prior to starting a shift?
Yeah, so this is a tough question. I feel like the whole concept of being on call is you really don't know what you're going to see. So it's really hard to prepare for everything that's going to come in. I think things that you can maybe prepare for is try to figure out where everything's at, because when you're on call, like your primary job really is to just help make the resident's life easier. And a lot of that is just getting things ready for them so that they can do their job more efficiently. So learning like where supply rooms are is really helpful. Learning where maybe like sometimes they keep local anesthetic in carts. So like learning how to access that so you can get, know where that's at to get that ready. But other than that, really, it's just experience. You kind of have to just start doing things, writing things down that you've seen and studying them, like on ortho bullets, so you get a little bit more familiar, like with certain fractures, what the treatment is likely going to be, so you can go get that stuff ready to go. But yeah, other than that, I mean, really the best teacher is just experience. And I think this came up a little bit in the previous panel. Like, if you're going to do a sub-I, maybe don't do your number one choice first. Do a different one that you can kind of use as a starter sub-I to like start learning how these things go. So by the time you get through them, you'll feel more comfortable. I think that's what happened with me towards the end of my sub-Is. I remembered things from previous sub-Is, and that's kind of the best way to prepare, in my opinion.
Yeah, kind of going off of that, it's definitely difficult to prepare for call because the whole idea is you don't know what's going to come in. And kind of building on what Dennis said is, if it's your first call shift with me or at the program, I'm not really expecting anyone to know that much. And I think that kind of goes, throughout different residency programs. But as you kind of take more call shifts, you see more things, and say you see a distal radius with me the first time you're on call. And then, we're on the third distal radius we've seen, I kind of expect you to know a little bit more how that goes, get stuff for sugar tongue, splint, things like that. And what Dennis was saying, as well as, kind of familiarizing yourself with where things are. One of the things that I try to do is, a lot of the hospitals have like punch codes for the supply rooms, is just write those all down in a notebook. So then I don't have to just bother the resident with one more thing. Oh, what was the code for this room again? And you can just go and get it, and then you have it there. And then otherwise, basic skills like suturing. We do all of our hand stuff kind of in the ED as the residents. We do nail bed repairs, lac repairs, anything like that. If you feel confident doing suturing, well, I'll let you suture at the bedside too. And that's kind of a good way to show you're suturing outside the OR as well, kind of with the residents.
Yeah, sounds good. Those are some good tips on how to prepare for a call shift. But kind of along those same lines, what are some of the bread and butter consults that you can expect to see while you're on a call shift? And I'll ask we'll start with Andy and then Dr. Ward.
Yeah, so I think that this can vary depending on the center you're at, both the volume of consults that you're seeing and the distribution of them. So you may be seeing a variety of things ranging from like low energy trauma from people falling and having distal radius fractures or hip fractures or proximal humerus fractures, You might also be involved with seeing and evaluating patients who have high velocity injuries, like from motor vehicle accidents and femoral shaft fractures or pelvic ring injuries. And these patients are often seen and assessed together in the trauma bay with other teams, like the emergency department, with acute care surgery and things like that. So I would just be prepared for anything. You may also be seeing pediatric call patients, which that might be a separate call pool, or it might be together with the adult consults, and that just varies by the institution you're at. And the volume of procedures that you might be expected to do or do with the residents, can also vary. And the pediatric consults tend to involve a higher amount of reduction and casting and things like that. So, that's just some of the variety of things you might be exposed to. And it really varies widely depending on where you are in the country and what institution you're at. So it's hard to give one answer to that.
Oh yeah, exactly. Just banking off that, what Andy was just saying, that it really just depends on where you are, and knowing what environment you are in during that time is about what you're going to see. I think everybody's mentioned the distal radius fracture, so you probably want to know that. I'd say knowing what things you would need to do for a distal radius fracture in the emergency room, but then the different hospital settings that you're in, whether it's a high energy level 1 trauma center versus a pediatric hospital versus a place where you're taking spine call as well, hand call. These things are all going to be institutionally dependent, but they all have their own specific things that they're looking for. Hand, you're looking for lacerations, whether or not a tendon was involved. Spine, you're looking for motor deficits, making sure that patients have appropriate reflexes. Then you have other things that, like you normally would see with your basic trauma patient, being able to assess certain limbs, splints, traction supplies. These are all very dependent on the location that you're at, but the more familiar you are and the more able you are to get that feel early on, then you can kind of be able to be prepared for it. So when you're walking into the emergency room, you're walking in to be that extension of your resident, you are ready to do that in an effective manner.
So what I'm getting so far is that call is all about there's variability and there's understanding your region, your environment, what service you're on. Yes, but it's really you don't know what's going to come in, and you just got to have that experience to be able to address that. Okay. So next question centers around, well, how do you take a consult as a seasoned attending, as a new intern? You have a consult that comes in through the ED, Dr. Ward first, and then Sam next. Walk us through how you would receive that consult, how you would prepare to see the patient, and then how you would execute and follow up on seeing that patient.
Oh, absolutely. I mean, even if I'm a faculty member, I don't have residents, or if I don't have medical students lucky enough to go examine the patient or see the patient, I have to get as much information I can from the person giving me that consult initially. And I have to begin to prioritize how emergent is that consult. Is this something that needs to be seen immediately? Is this something that I can get some more information on? Things like compartment syndrome, cauda equina syndrome, these flexor tendinosynovitis, these quote unquote orthopedic emergencies are ones that we really want to be more prudent about seeing immediately, and then basically working my way backwards from the more emergent conditions to being able to take a step back, notice what types of laboratory work, what type of imaging has been obtained, how much can that person that I'm getting to give me the consult over the phone to give me that information. But then if I'm at a place where I have residents and I have people that are able to evaluate the patient initially, that's where I'm relying on the resident as a faculty perspective to be that extension of me, in the same way that I want that resident to be able to go and evaluate the patient, know what things I should be looking out for when I'm seeing that patient, and then be able to appropriately get that patient at least towards the treatment plan. Even if they don't know exactly what that treatment plan is, being able to make sure that we have all the information that we need to make that decision. There's some conditions that are you get a consult for that are controversial. Some places treat it one way versus another way. But if you have the information to help whoever you are trying to present that information to make that decision, that makes things so much better. And as a medical student, you're basically, like I said before, the extension of the resident. And that's how you are able to you should basically treat yourself as a resident presenting to a faculty member, or just presenting that information to somebody else. And that's how I kind of would approach the initial portions of getting that call, that consult.
Awesome. Yeah. Exactly. Building off of that, like as the first year like intern, you're probably the one getting the call. And if you're the med student, you're going to be with me likely. So number one thing, like Dr. Ward said, is determining how urgent or emergent is this? Is this a compartment syndrome? Is this a cauda equina? Is this something that I need to essentially drop everything I'm seeing and go see this next? You know, in summer trauma season, you may be 4 or 5 consults behind already. Is this the next one I go see, or is this one that I look and go next? And then after that, it's looking at the imaging, you know, or if you're not even by a computer, because a lot of the time I try and take these while I'm walking around doing other things. It's what imaging do you have? And you just kind of ask and get the whole story. And you can kind of say, well, you know, for any ortho injury, it's generally one joint above, one joint below for any injury. So making sure that they have all the appropriate imaging so that when you do go see them, it's, you know, appropriate that you have everything you need. If it's an infection, you know, what's their lab values? What are those different things? And then once I actually go see the consults, even though I have a general idea of what's going on or what the issue is, if it's some kind of broken bone, I obviously already know that based off the imaging and what the providers have told me. But then going in and getting my own story too. I'm sure we've all been that medical student that's gotten a story from a patient, and then the attending walks in and boom, the story changes a little bit or a lot of it. So going in and figuring out what's really going on, hearing it from their side, get the story from their own words, making sure you know kind of, it probably varies from place to place, but depending on where you go, kind of watching and listening to what the residents ask for. So for us specifically, anytime we go into a consult, we always ask for phone number for follow-up. We always ask for occupation, and then we always ask for occupational status. So like, what do they do? Things like that. And I mean, that's always a good thing to have, but it may be different from place to place. So if you watch a resident do that, and that's the questions that they're asking, it's also helpful if you go in and get the history and do that so that we don't have to come back in and ask. And it just shows that you're also paying attention to what we're doing and helping us in the long run. And then finally, kind of, it depends on what the overall consult is, what you're doing when you get in there. Like Dr. Ward mentioned, you know, it could be a spine consult, it could be a hand consult. Those are very different consults for what you're doing. I think generally, if you're doing the physical exam by yourself and then going back and telling the resident, just, you know, go through the same thing you would anywhere else. Look first, see what you're seeing. Is there a deformity? Is there bruising? Is it an infection? Is there some kind of pus draining from that wound? And then, you know, feeling, where is it tender, everything like that. And then kind of going into those special tests. And a lot of those different ones, like there's a bunch of different spine special tests there. For hand, there's a ton of different special tests that we don't expect you to do as residents. I probably don't even know all those tests as an intern. But at least you have that idea of what's going on. And then the resident, you can, you know, tell that to the resident, and then they can at least have a better idea of what's going on if you're the first one going into the room.
That was really great, Samuel. And if I might just add one thing too, I think, you know, a lot of people have mentioned, you know, you want to help out the resident or do things for the resident. And that's, you know, obviously people appreciate that. But I think the best way to maximize the experience for yourself is trying to learn as much as you can from the individual consults that you see. As we've discussed, you know, you're not going to be able to see everything, and what you're going to see is going to vary widely. But if you can read as much as you can before you see the consult, after you see the consult, the next time you see that same consult, you're going to be that much more knowledgeable. And over time, the things that are common are going to be, you will have read a lot more about. And the people who do that kind of thing end up just being more helpful because they know what's going on. And Samuel mentioned a lot of things like looking at the imaging, and that seems obvious, but as a medical student, you might not initially have access to the imaging system, and that's something you can get access to, and you should figure out how to get access to it. And you can look through the imaging whenever you want. You can determine, do we have adequate radiographs? What radiographs do we even need for this fracture? Are the radiographs good enough? And these can be complicated questions, but you can start to figure out and think as if you were a resident, and you might say, oh, we don't have radiographs of the femur. Do we need those? You can ask the resident, do we need those? And then you might actually need them, and that might be something you picked up on. Anyways, it's just, there are a lot of details that were kind of in that answer that you can get better at.
Yeah, you guys actually kind of answered my next question, so I'm just gonna skip that question and go to the next one. So I'll ask Olivia and then Sam. So there may be like some quiet stretches during a shift. So whenever there's some downtime on call, what do you recommend students do to maximize their learning?
So similar to what Dr. Harris just said, when there's downtime, that's a good time to read about common consults that you might see on call, or maybe you just went and saw something that you hadn't seen before, or maybe you weren't exactly sure like what the process or the workup for that consult was. Take that time to go to ortho bullets. If it's a surgical case, to go to Hoppenfeld's or the AO reference to look at the surgical approaches. And I would try to like consolidate information. So for the things that you would see most commonly on call, have like a little note on your computer or wherever. You kind of just go through the steps of what you would do if you got that consult, and you kind of build on that as you go through your away rotations throughout the year. So that's a great time to read and study. It also can be a good time to prepare for cases for the next day. So if you can look at the OR schedule for the next day and see what's on there, prepare for those cases, prepare for those approaches, prepare for that anatomy. On some of my sub-Is, I also had to give a presentation about an orthopedic topic or a case that I had seen at the end of the rotation. So I would sometimes use that time to work on that presentation as well.
Yeah, those are some great answers. Kind of building on that too, I would say, yes, it's great to go and read on ortho bullets. I would say that's probably a number one thing. Like what Andy was saying, learn from your consults. That's the best way to do it. But another thing, you have to kind of feel out the situation. If the residents, also has a little bit of time, they're not like writing a ton of notes or catching up on things. It's always a great time to ask us, if you had a question, why did you do this? And sometimes you can't find that answer on ortho bullets. And sometimes we have a good answer. Sometimes we may not have a good answer. Sometimes it may be based off of our other experience. Like we keep talking about, the more experience you have, you kind of learn different tricks. So I may have a different trick for reducing a distal radius that someone else doesn't do. And I've already found that between my residency, learning from the second and third years, each one kind of does it a little bit differently. And then you kind of learn some of those nuances for what are we trying to do with this? And then if you do, and if you don't have any questions, you can, go on and say, what's the treatment for this? Is this surgical? What's the plan going to be in the OR? Even if you're not scrubbing that case the next day or whenever that is, at least then you kind of know the time course for this injury. What's their recovery like? Things like that, just to show that you're kind of thinking through the whole process is helpful to see as well.
Yeah, it sounds like from both of you that you want to be proactive, both in how you use your time as well as the learning and being curious and building on the basic structure of how to handle a distal radius, and then the next steps and the next steps and the whys. So that was really good perspective. Kind of transitioning from maybe a slower call to a more busy call. The next question focuses on that social awareness a student might have while being on call. I'll start with Andy, and then we'll pass it over to Dennis. Do you have any recommendations how a student can be proactive and socially aware when it's flooded? It's a busy shift and you're going and you're a resident?
Yeah, that's a great question. Obviously, things can get busy. There's often a lot going on, and the resident you're with might not have the time to be teaching you many things, or I don't know, answering questions about other rotations and stuff like that. And I think it's pretty easy to see how busy they are and how many other things might be going on. I think that one way to deal with that situation is, I think all residents have a way of keeping track of the consults and the information about those consults. And if not, you can create your own sheet to keep track of those things, and kind of putting yourself in the shoes of the resident. And if you try and gather as much information as you can separately and try and stay organized, and knowing where patients are, where certain people are, having that information can only be helpful. I think that, some of these hospitals are also very big, and you might need to meet a resident at a certain place. And if it's busier, it's obviously not the best thing to have the resident have to go across the hospital to meet you and find you and stuff like that. So having a good lay of the land before you start any rotation, but like with where things are, is, I think, very important. And you can anticipate, where is this person going to be if I'm not with them, and you can meet them at the patient's room. You can suggest that, hey, I'll just meet you at this patient's room. I know you're going to be here in like 5 minutes. And, that just makes things easier without adding to the stress of a busier call shift. And yeah, I mean, there are obviously certain times when it's best to just sit back and observe and watch how the resident is handling things. And it might not be the best time for you to get involved if things are really busy, but that, just takes a certain level of awareness and thoughtfulness of when you're with residents on call.
Yeah, just to kind of add to that, I mean, you always want to be prepared, and always want to be able to make sure that you have that information ready to go. You may just know what things you can do. There's a lot of things that you could do that could decrease the resident's time immensely. Get basic history, medical history, surgical history, social history, all these things that that the resident's going to need anyway. Just making sure that you can divide and conquer, kind of utilize yourself as a teammate, and be able to do the things that are within your scope of practice.
Yeah, I think Andy and Dr. Ward covered a lot of things I was going to say too. I think when things get really busy, what I try to do is just constantly reassess myself and think, what's going on? What are things that I can help with to help relieve some of the load that the resident has? And just try to check what are some small things you could do to help make things more efficient. I would also add, if the resident's sort of comfortable with you doing this, dividing and conquering is huge. If there's a big list of consults that need to be seen, if there's some other stuff that you can go and get started while they're simultaneously doing something else, that's really big. That kind of builds upon what I was talking about earlier, and what also Andy mentioned, is knowing where things are can make things, can help with this specific moment. So you know where to get supplies, where patients are, things like that. Also having a good having like the resident's phone number is huge, a way to contact them, so you don't have to constantly try to track them down to talk with them. You can text them and be like, I'm going to go be at this patient's room, I'll meet you there, or I'll get these supplies ready. Or you can even like send pictures of what the wounds or injuries look like, so they can kind of tell you what you should get ready and what things should be, what you can start, setting up for them. Yeah, I think those are really big ones. And then also, like Andy said, if you really don't know what to do and the resident's obviously very busy, sometimes just stepping back and staying out of the way is the best thing you can do, coming into that social awareness aspect. But yeah, I think those are some of the tips that I would give.
Those are really good tips as far as, that social awareness. I want to have one just quick follow-up question on something I've come across in shadowing and helping out, and that's regarding consent forms. Can Dennis, Dr. Ward, or Andy introduce consent forms and maybe ask or explain a little bit how medical students can get involved and be helpful with those?
I think the rules vary by institution, and at most places, I don't think that you can witness consents. You obviously can't be the person consenting patients, but if anything, the thing you might be able to help with is typing up the consents, which would involve you clarifying exactly what's needed with the resident before you do that, because obviously the consent process is very critical, and doing something incorrectly could result in a big problem. So, that's one thing you might be able to ask about, like, can I type up the consent for this patient, or have a blank one? And some people use paper consent. You can just have them with you and give them a blank form. But I'd be very careful about that, and realize that the rules at different institutions may vary in terms of how much you're able to help with those types of things. But even just understanding that all patients who are going to get surgery need a consent done is something that many people don't realize. And if you see a patient that is going to need surgery, the resident it might be best if they do that consent process right then, and even just prompting them saying, hey, should we consent this person right now? That might be very helpful in and of itself. So, but yeah, and you know, along the same lines, it might seem like you can be really helpful if you type up a consent for somebody, but that, among many other things, is one way that you could do something that would end up causing more problems than helping if you don't do it right. And the only way to know that you're doing it right is by asking. And even if you've seen the same fracture several times, they've done the same thing, this one might be different, and you can't necessarily make the assumption that we're going to do the same thing we did last time. So communication is key in that case.
Andy, I think that's great perspective, and there's a bit of a black box or a little bit of variability for med students around that with whom I've talked with. So that clarification and emphasizing the importance and the you know, maybe avoiding it, but understanding the process is very helpful. Cassidy, I'll pass it back to you.
Yeah, so as we're talking about busy call shifts and long shifts, I wanted to talk about burnout while you're on a call shift. So it can be hard to stay awake for that long shift and stay focused and get everything done. So I'll ask Dennis and then Dr. Ward and whoever else wants to pitch in. What are some strategies you recommend to prevent getting burnt out on call?
First thing that comes to mind for me is Celsius, but definitely strategic caffeine, I think, is huge. But other than that, I mean, if you're going and it's a really busy night, I feel like there's like kind of not a lot of time to really think about how tired you are. But if you are having some downtime and you're sitting there, you know, obviously we talked about reading up on things and being productive, but also just like don't underestimate the effectiveness of just getting up and stretching, walking around a little bit, trying to keep yourself active. And then also, I think something for me that really prevented burnout is just if you have good like camaraderie with the residents that you're working with, it can actually be pretty fun. Just like, you know, if the time allows, just joking around with them, talking with them. A lot of the residents that I was on call with would always like buy food for us. So that's a great time to kind of eat together and again, develop those relationships and kind of keep morale high. But yeah, those are things I can think of.
Yeah, during the call shifts, I remember a bunch of residents just basically blaring music, having a good time. Basically, the busy call shifts are easy because you're going through, your adrenaline's going, all that stuff's just full force. And then the slower call shifts are ones where you kind of get a little tired. You need that caffeine, you need that something to keep you active, something to read on, something to review. But unfortunately, I think one of the big things is that you're going to hit that at you're going to get that big adrenaline surge overnight with all that stuff going on. And then you're going to get in that morning report. You're going to get in that morning fracture conference, and it's just going to be a nice dark room. You're looking at all the radiographs. And that's when you get really tired. You just want to try to keep as focused as you possibly can on what's going on. So that way you're not going to be seen as the person that's dozing off in the middle of that conference in the morning. So just doing your best to make sure that if you keep yourself engaged, keep yourself up to date with what the resident's presenting, making sure that the resident is presenting the accurate information, or, just making sure that you're keeping involved, then that should help you stay awake during those times. It's just after a 24-hour shift, it can be really tough. Just be mindful of those little moments in the morning conference when literally a majority of the faculty may be there in the morning, majority of the residents may be in the morning, and you want to be able to be seen as that person that can really go and drive through. In addition, if you're able to, if you end up getting plaster or unfortunately some other bodily fluids all over your scrubs, go ahead and change. Get yourself to a fresh set of clothes. If you have a fresh pair of socks or a fresh pair of underwear somewhere that you can just completely change and get yourself presentable for the morning report. If you had that downtime, that's great too. It puts you in a positive mentality and ready to go, ready to tackle the next day. So those are things I'd recommend.
Can I add, don't be a hero. If you have a post-call day, take it. If your resident tells you to go home, go home. Sub-I season is long and you'll get burnt out really easily if you try to be like, oh, I can stay for another case. I can stay for this. I can stay for that. Take your post-call days and sleep and drink water in addition to Celsius.
Duty hours are insanely important. Make sure that you adhere to them. And when they say go home, it's time to go home.
Okay. little self-care, enjoying that time, but and also being present for the next morning, but also definitely taking care of yourself in regards to call. With that, maybe just one quick follow-up question to Olivia. Can you talk us through some of the tasks, how that handover at the end of a shift happens? Some of the logistical pieces, as well as advice for a med student finishing a shift and that self-reflection or reflection with the resident. Can you just provide some color around the back half of a call shift?
Yeah, so usually what you'll do is you'll pre-round in the morning before everybody gets together to run the list in the morning. So I think it was previously mentioned that's a good time to figure out like what did this patient do overnight? What did they do with physical therapy the night before? What if they have new labs? What like update the labs on the sheet or however the program does their running of the list. But basically just having the most up-to-date information about the patients that you saw overnight or new patients that got added overnight is what you want to do. Again, it depends on the institution and how long you've been there and how well they know you about like what they'll let you do in those pre-rounding tasks. But some places that I went, they would have the medical students pull drains. You might like help with a dressing change. Always remember to take a picture if you're doing a dressing change. Take a picture of the incision and share that with the residents. But yeah, those are some like basic tasks you can do in the morning. But yeah, just be prepared with the most updated information about new patients that came in overnight for running the list in the morning.
Okay, so this next question, I'm going to start with Dennis and then Sam. How did you interact with, or how do you recommend interacting with those fellow student rotators to maximize each of your successes during a rotation, specifically in regards to taking call?
So this might vary by institution, but for me, it was always just one student on call each night. So I didn't really have to interact with other students while on call. But I will say, like during the rotation itself, don't be that person that's trying to, like obviously look better than everybody else because it's very noticeable. The way I treated it is I would just try to be friends with the other people as much as I can. I mean, these people might be your potential colleagues in the future. You don't really want to like put anybody down or create any enemies. And also it just helps like the whole rotation go more smoothly if you're friendly with everybody. I mean, sometimes the rotation will work where they kind of let all the sub-Is kind of to their own devices to divide up the call shifts. So, I mean, if you're friendly with people and let's say you needed to take a specific day on call, another didn't work, then you can ask them to kind of cover for you for that type of scenario. But yeah, really just trying to be friendly with everybody. I mean, I know at the end of the day, you're trying to look as good as you can, but you can do that without having to put other people down.
Yeah, exactly. It can be definitely kind of tough to think about them as, a competitor, because at the end of the day, you are trying to match and so are they. And obviously you guys are both interested in the same location if you're both rotating there. But it's exactly that. It's usually one person on call, at least when I was doing my away rotation. So there wasn't like too much stepping on other people's toes. I will say that I did rotate, or I did have a call shift with one other student one time. And it was basically just kind of building off of each other. It was like, okay, we have 4 consults. I'll go get the splint stuff for this. He'll go get the splint stuff for that. And basically it's just having 2 extra sets of hands for those residents on call. And I think it helped out immensely that, if you can show that you can play well with others, even if they are your like competitors, but to be fair, they are your colleagues as well, and they will be. Ortho's a small world, like whether you like it or not, these people are going to be likely matching somewhere else. So, I mean, everyone that I essentially rotated with are residents somewhere. And the one time I was on the call shift, he is actually my co-intern now. So it ended up working out well. I guess we had a great call shift. So showing that you can play well and be nice and kind of use each other and build off each other to get a ton of stuff done in an efficient manner, because all the extra hands help, and just not trying to put other people down is huge. And it goes a long way too, even if you don't think that, if you're the one that, isn't, someone's maybe saying something that was kind of hurtful to you, and you may not think the resident sees it or whatever. We do. So just be nice to everyone, regardless of who it is.
That was a great perspective, Sam, both from the, definitely from the soft skills side. And I think throughout this whole discussion, we've talked about the variability, the proactivity, how you can learn some of the tangible things that you'll need to take care of on call, but also take care of yourself. And again, we're play well with others, as you said. This is our last question. We have everyone who is joining us, feel free to add more to the chat. But I just wanted to start with Dr. Ward in kind of closing. What are the qualities that a student can have or things that they can do to really make them stand out as far as call?
Oh, yeah. And so when you're a medical student, you're on call. And I think we've kind of all harped on that, that you are the extension of the resident. You're basically trying to work as a team with that resident overnight. So essentially, if you're a really great resident or a really great medical student, you've made your resident look really good in that morning report. You've made that resident know all the information that they need to know. If you're on top of things, and one of the things I highly recommend I put in the chat is that you keep your own consult list. You keep your own list of patients, so that way you're keeping track of the same things that the resident's keeping track of. And so if there happens to be a scenario in which, say, the resident who's been working nights for a week and a half and they're tired, they're worried about everything, they might have forgotten something, then you're that person that can harp in and say, well, we forget to get the consent on that guy that's going to the operating room first case. We might, I can go ahead and get that prepared. We can get that taken care of, and you can do that while I go take care of this right before morning report. And you want to, and when you're doing those things, it's obvious as a faculty member when we get to that point that the resident is 100% engaged and know all the information. I even had a scenario where a medical student was able to provide us with the lab value that we needed in the morning report that everybody else was just looking up. They just had on their sheet, say, oh, hemoglobin A1C was so-and-so. I was like, well, that's great. And then we don't have to waste 5 minutes of people searching on the EMR in order to get that information. It just shows that that medical student is taking the extra step, being that resident. Every medical faculty member wants to hear about that medical student that is able to function at the level of a resident. And so if you're able to do that and anticipate the next step and the ways that everybody here has been kind of describing, then that just goes a really long way, as opposed to just being a passive learner. If you're actively involved in patient care, that speaks volumes.
All right, I think we are out of time, but thank you so much to all of our panelists for all the great tips and tricks. And we'll go ahead and hand it back over to Ryan and Jess to introduce our next panel. Thank you, guys.